This is new cases by race and gender. Again, remember, I think the population of African Americans in Washington was around 3%, but again, much higher burden of the dark bars being male and the light ones being female. And these are the living cases, not the people who are diagnosed, but actually people who are living with it. And again, it's the same trend. Okay, this is another segue. This is, I can't remember where I took this. It might have been Costa Rica. My Spanish is not very good. And I actually had a Hispanic speaking person in my office this week, and I said, hey, come here, do me a favor. What's this first sentence say? She said, it's, a slogan, it's slang in that country, but it sort of says, nobody's safe, don't give yourself up to death or, give yourself into the air. But the second part I can read pretty well, and it says the virus is contained in semen, vaginal secretions, and in the blood of people who are infected. So it's just sort of, neighborhoods putting up information about HIV. Okay, now the more entertaining stuff and the gross pictures that everybody likes. So here's a case. 27-year-old guy comes in, fevers, tired. This is what his throat looks like. The picture of his neck is really hard to see, but he's got this faint little lacy rash. Well, if any of you had this throat, you would say, it's strep throat. Looks like it. But another bit of history is a week ago he had high-risk sex with 2 different men. So this is what acute HIV looks like. It's pretty difficult to diagnose. It's not in most people's mind when people come in with these symptoms, and so it's often missed. And when you look at what acute syndrome is, and again, here's a list, you can refer back to it, it's pretty much in the order of what's more common. So fever, malaise, swollen glands, sore throat, rash. I mean, how many of us have not had those symptoms? So you go into a walk-in clinic, again, HIV is not in the forefront of most providers' minds, and so this gets missed. This is a separate case of 2 different people, mouth lesions. The lower one is thrush, and the upper one is something called oral hairy leukoplasia. And that's just it's sort of a white area on the tongue. The one on the bottom where you see it on the top of the roof of their mouth, that you can kind of scrape off, kind of look at it under the microscope and see fungus. The one on the tongue, you can't. It just sort of stays there. It doesn't hurt people, but they just sort of look at their tongue and go, wow, what's that? It's really weird. When they get it, it really is a manifestation of low immune system that's pretty suppressed. Before we had medication, 15 to 20% of HIV people had this, but now we're not seeing it. It responds well to medication, the HIV meds, and it may be related to Epstein-Barr virus, the one that gives mononucleosis, but not quite sure about that. I don't really see it much anymore. All right, this is a case where the case is real, the pictures are not from this person, but they could have been. So this is from a 48-year-old woman. She's Cambodian. She immigrated 3 years ago. And you think that when they immigrate that they get put through a battery of tests to figure out what's going on. So she came in, she was having several weeks, she was just feeling poorly, short of breath, and it was just getting worse and worse and worse. And she had low-grade fevers, and she had weight loss. And I don't know if you can see on the upper x-ray, it's on your left, up at the top, it looks kind of fuzzy. We call it ground glass. It just doesn't look normal. For comparison, the lower one is a normal x-ray, just so you can see the difference. And so she ended up getting diagnosed with pneumocystis, which is pretty much a common way of presenting for HIV. So she got started on antibiotics and steroids, which is very common. And she got better. Then she went home, and 3 weeks later, her shortness of breath got much, much worse. She developed cough and higher fevers. And so she had another x-ray, and again, this is not her, but it could have been. And now she has miliary TB, which is sort of a disseminated TB, probably set off by steroids. And the smaller slide shows a typical presentation of somebody with TB, where it's sort of just at the upper top of the lungs. And you can see it's kind of diffuse there. So she got treated for that. She was very sick, probably had T cells around 20 to 50 at the time. I still see her. She's doing quite well. Her viral load is undetectable. Her T cells are over 900. I don't get to see her often because she works and she doesn't like to take time off to come in to see me. And so, she's doing so well. This is a case of maybe a 30-year-old. Somebody comes in with a rash. You look close. It's got those blisters. This is shingles, herpes zoster. And before, when people would get chickenpox, before they were vaccinated, seeing shingles in a young person is pretty unusual. And whenever I see it, I think HIV, lymphoma, leukemia, something going on. But now when the young folks are getting vaccinated for varicella, it's more likely that they're going to get shingles for whatever reason. So this is another way that people present. Actually, just saw somebody yesterday. He is a man who has sex with man. He is doing a gender transition, changing to be female. Came in, I hadn't seen him in 2 years. He was been down in LA, had a really bad case of shingles. And although it looks like, you get the rash and it goes away, it lingers, and it can linger for up to a year. He's pretty uncomfortable. He's mostly upset because he got it on his implants, and he's worried that something's going to happen to him, but here's another one, head CT on the left, normal on the right. You can see that big old circle, probably not normal. 45-year-old female, she comes in, acute onset of headache. It just started pretty bad. She's got fevers, she's got motor weakness, and she's having trouble speaking. So you get a imaging study of her brain and you go, not normal. This is toxoplasmosis. Have not seen it in a long time. Again, people are getting diagnosed, they get on medication. These are called opportunistic infections, which means that if your immune system is intact, you don't get them, but they're opportunistic in the fact that they find people who have a low T cell count and then are able to cause a problem. Actually, most of these infections we've all had, and we're able to contain ourselves, but when our T cells go down, they're able to overcome it. This is treatable. The person does quite well. So talking about the different things, this is a classic slide that I've seen for years and years and years, and T cells along the axis, and along the bottom part is the year of HIV. This is without medication. You can see that over time T cells go down, and when you get to certain T cells, you're more prone to certain infections, like the tuberculosis that we talked about, pneumocystis we talked about, and the toxo we talked about as well as a fungal infection. And you can see that one patient that I lost this last year had the MAC down at the bottom, and so his T cells were very, very low. So, okay, what about how much are we seeing of these opportunistic infections? So this is a slide of pre-HAART, the highly active medication, versus post. And you can see I sort of just try to color code it. So the pneumocystis before, this is per 100 patient years. It means that you have one person that you follow for a year. If you have 100 people you follow for a year, that's considered 100 patient years. And it's really, you can see a huge drop in opportunistic infections, and again, I think we can thank the fact that we have good medication to keep people's immune system intact. This is a case, and I saw this guy on Monday, actually. He came in not to see me. He wasn't a patient at the time, had this rash on his leg, and then he had these purplish toes. Saw the dermatologist. Dermatologist said, haven't a clue, did a biopsy. Called him on the phone and said, you have Kaposi sarcoma. Now this is something that I've not seen in years. And she says to him over the phone, this is related to HIV, we need to do an HIV test. So he came in, got an HIV test. She called him up over the phone and said, you have HIV. Now, as you can tell, this is not the way that I would give somebody a diagnosis. However, I wasn't in charge at the time. He's a 50-year-old Caucasian male. He's a school teacher. He has a male partner. And so this is Kaposi sarcoma. It is a type of cancer. It can be treated by radiation, chemotherapy, systemic, or they can actually inject right into the lesion. Or this guy is going to be getting, we're just putting him on HIV medication, get his immune system back up, and it should probably clear. When he first came in, his T cells were about 259, which isn't that low, and his viral load was 28,000. He was a little bit complicated because his virus was very resistant to multiple medications. So I started him on meds, and so again, viral load before meds was 28,000. A month after being on them, they dropped to under 1,000, which is an excellent response. He's going to be fine, and these lesions are going to go away and not be a problem. So these are non-infectious complications, and I just had to get a picture of my little puppy in there. So anyway, sorry. All right, lipodystrophy. This is fat accumulation or fat loss. Smile, everybody. It's kind of a joke. All right. But it's true. This is what happens. People get fat built up on the back of their neck. The picture that I have trouble figuring out what it is, but I believe it's a knee, and you can see the muscle and the blood vessels really well. So he's lost a lot of his subcutaneous fat, and it actually ends up accumulating in the body. In women, I have a lot of women complain that their breasts are getting bigger, and it's really uncomfortable. Again, fat deposition. This other gentleman has loss of his fat pads in his cheeks right here. This is not my patient, but I have a patient that looks just like this, and he does not like going shopping because he thinks he looks like a meth head, and that when he says when he goes into stores he gets followed around by security. So it's really a big stigma. There are treatments for that, of course. Insurance doesn't cover it, but there are things that can be done. Also, cardiovascular disease. So somebody who's HIV positive, it's as if you're HIV negative and add on 25 years. I've had 3 men, all 3 of them men have sex with men, came in with chest pain. They were all under the age of 40. One of them dropped dead at home once, of course once, but because of heart disease. The other 2 ended up having stents. So think about it. Even heart disease in people under 40 is pretty uncommon, but starting to see that, just the premature arterial sclerosis. To give you an idea, exposure to medication over time, and you can see the line goes up. So over 4 years, you're at much higher risk of having an MI than when you first start the medication. But it's related to some of the medications, and I'm hoping that the person who talks about meds later today will talk a little bit more about it. This is diabetes, which is also, not considered an HIV disease, but the incidence is going up. You can see people with HIV are in the white over age, and the people who don't have HIV, it's also increasing with age, but it's not as much. Also changes bones. This is a picture, and you see the arrows looking at the femoral head. So we're looking at your thigh bone, and up here is the ball, and we're looking at the ball, and you can see that line right across it. There's something called avascular necrosis, which the blood supply to the top of the hip dies, and so the bone dies. And I have 2 people, actually almost 3 people that have had this, and they end up having to have their hips replaced. And one of them, it's the same guy that had a heart attack. He's not doing so well in terms of his luck. And he was I think he was 38 when he got his hip replaced. Although he has these things, he's out now doing quite well. His viral load's undetectable. He's went back to school and is a medical assistant. He's working, so he's doing well. Also, osteoporosis is not something that we think about in men, and certainly not in young people. So if you've had HIV over 11 years, your risk of having osteoporosis goes up by 31%. Medication. So the virus can increase your risk of osteoporosis. Being on medication, if you're on medication over 10 years, you have a 36% increase in the rate. And these are two different types of medication. This is a non-nucleoside, and that increases your risk by 37%. And if you're on a protease inhibitor, which I keep alluding to, really changed the scene of HIV, but here I'm showing you that if you're on it for over 10 years, 64% of the people have osteoporosis. That's a pretty high percentage. Also, we have dementia. Before we've had the protease inhibitors and other meds, 30% of the people with HIV had dementia. And it's important because obviously they have difficulty getting along in the world, but also when they have dementia, it interferes with their ability to stay on the medication. So it's sort of this vicious cycle that they get sicker and sicker. Post-heart, we are seeing some impairment in thought processes, and it's occurring despite having an undetectable viral load. And not quite sure what's going on, and it's slowly progressive. Not everybody gets it, but it's out there. This is a picture of, I was in Portugal, walking around the square that they have, and outside the pharmacy, they had a condom dispenser. And I'm assuming, again, this is in response to HIV problems. So, whirlwind tour, kind of tried to cover everything. The only thing I forgot to talk about was age range, and it's a bell-shaped curve of who's getting it, and it peaks around 20 to 29 and then goes back down. So the thing to remember, this is really preventable disease, and these are different ways. The nurse sent me that postcard, my nurse from Mexico. You look at it, you'll figure it out in a little bit. And then I have that button that I only get to wear 1 month out of the year. And then one of my friends is an occupational medicine doctor, and she took this picture of this guy that had safe sex tattooed on his middle finger. Good question. So the question is, when do they come into my care? When am I seeing them? I work out in Mukilteo, and again, I've been there 20 years. In all those 20 years, I've only personally diagnosed one person HIV positive. Not a big surprise. He was having unsafe sex with one of my patients who was positive. So, it's just a matter of time. Most all the other people are referred to me. She came to me after the hospitalization and was doing well. The gentleman that came in with a Kaposi sarcoma, as soon as he got diagnosed, he got sent to me. So I'm not finding HIV, giving them the first diagnosis, but in my clinic, there's about 400 docs. I'm in a big multi-specialty clinic, and so they all know that I do HIV, so once they get diagnosed, they get booted to me. That one gentleman that died from the MAC, he was diagnosed at the health department and then sent to me, so I got him pretty early on.
So let's begin. So I'm assuming most of you are here because you'll be very soon, or you've already gotten a job in healthcare. And like the previous speaker said, you have to take this class, which is a very good thing, because What I'm going to talk to you about now is how to stay safe. You've got all the information as far as AIDS goes, but you need to know that there's more than AIDS and HIV out there. And there's very easy things you can do to keep safe in your new workplace. It's all about keeping you safe, the patient safe, and your family and your coworkers safe. It's easy, it saves lives, it's very simple to do, and it's just the right thing and the safe thing to do. We're going to talk to you about what actually you need to do to stay safe and to provide a safe work environment, and if you should happen to see unsafe work practices where you go to work, that you do something about it, and that you need to understand what the right thing to do is. We're going to talk about personal health risks while you're at work, plus your personal risks in your everyday life. Key infection prevention principles. We used to be called infection control years ago, and sometimes wherever you go to work, you'll see that phrase, infection control. The truth is we're in control of nothing. We're not much different than parents of teenagers. It's all about prevention these days. So we're going to make sure that you don't pick up something from work or even something from the people you live with. We're going to talk about applications in your work settings and identify resources. So if you want to read on and learn more, this is just the basic stuff. And there's a lot more to learn and a lot better information out there than just this. So in your workplace where you go to work, resources for information is, of course, employee health. And if there's an infection prevention department, obviously you can call them up. There has to be policies, procedures at work, and protocols that you have to follow. And they're written there for a reason. They're not just window dressing. They're there to keep you safe because there's a law saying that your employer has to do this. The Department of Health is an excellent resource for further information. And of course, my favorite, the CDC. And you can also go to the World Health Organization. And I have links for all of those there, and you can type those in at any time. So you already know a lot about disease transmission from the previous speaker, but there's a chain of events that have to happen before you can pick up something from somebody at work, for instance. First of all, you have to have the infectious agent. And we could talk about HIV because you already have information on that. It is out there. It's here to stay. It's not going anywhere. And there are people out there. So that's the infectious agent. The next link is a reservoir, and there are people who are positive, as you learned earlier, and so you need to be aware that they are out there. The portal of exit, that means there must be a way to get the infectious agent from them to you. And if you work in healthcare, we're going to talk about what the various transmission possibilities are, but in healthcare, most of the time it's a needle stick, a contaminated needle stick, and that's the portal of exit. The means of transmission is how does that happen? So if we were talking about TB, the means of transmission would be in the air. Somebody would be coughing and it'd be in the air. In this regard for HIV, it would be the needle itself, the hollow bore needle that is contaminated and that you stick yourself with it. The next chain is the portal of entry. So in HIV, that would be the actual needle stick that goes into a soft body part, usually a finger or a hand, and then you are a susceptible host because there is no immunity from HIV. So you have to do all of these things in order to have an infection, and it could be HIV, could be pertussis, for those of you who are aware of our pertussis outbreak right now. It's the same thing. All you have to do to stop infection is just to break one of those chains. An easy thing to do. The easiest thing to stop the chain of infection is hand hygiene. It's something that is simple, it's cheap, and none of us do enough of it. So how many of you touched the doorknob out in the front when you walked in the door? Okay, your hand is contaminated by everybody else who touched that door before you did. So if you have a gel, alcohol gel in your pocket or in your purse, wouldn't be a bad thing to use it, you know. And so that's a big thing. In your workplace, standard precautions as what we want you to use. And that's just a simple, we're going to talk about that. And then isolation instructions. So the isolation, when we isolate patients in healthcare, it's because they have something that's very easily transmitted. And we want to keep it moving from that patient via you to other patients. And so we put them in isolation. And then the other key thing is keep your immunizations up. So get your pertussis vaccine right now, since we're in the middle of an outbreak. But all vaccines, flu, measles, mumps, rubella, all of those, you need to get your vaccine. So we have to talk about, because it's the law, we have to talk about bloodborne pathogens. And you already know about HIV, you just heard about it. But there are two other things out there, hepatitis B and hepatitis C. And all of these are spread exactly the same way through contact with infected blood and other bloody body fluids known as other potentially infected materials. This is a picture of what the AIDS virus looks like, and you've already seen this. It's actually a very fragile virus. It does not live very long outside the human body. So it's actually a very difficult thing to pick up, really. It's not like the flu, which is really easy to pick up. If AIDS was as easy to pick up as the flu, we'd be in really big trouble. HIV is hard to get. All of these are in our community, but they're all easily preventable. Unprotected sex is a good way to get this. Sharing needles and syringes, blood exposure to mucous membrane or other open wounds. This is what happens in your workplace, and you need to be aware of it. Of course, you learned about birth and before and during birth, and it's transmitted through breast milk. So women who are positive for HIV cannot breastfeed their babies. An easy thing, because we have all this wonderful formula out there. Before 1985, there was transmission through blood transfusions and blood products, but now we test for all of those, and they are not out there as a point of infection anymore. It is not transmitted, like remember I said, it's very difficult to pick up, really. It is not transmitted by casual contact. So if I had it, I could shake your hand, I could give you a hug, I could even give you a big kiss, and you wouldn't get HIV. So it's not transmitted through kissing, touching, shaking hands, or hugging, being in the bathroom, on the toilet, none of that. Coughing, saliva, none of that. Eating, you can share utensils, none of that. It's not in the swimming pools. And it's when you care for your patients, you will not be picking it up by casual patient care. It is transmissible in healthcare. Yes, it can and it does happen. Not very often, but it does happen, and you need to be aware of it. It is manageable, and it's all about your behavior and what you do at work that reduces your transmission possibilities. It happens by a contaminated needle stick, usually in healthcare, or a sharp injury of some kind, such as a contaminated scalpel. There are blood exposures that happen in your face via your eyes, nose, and mouth. The risk is very low. And then any exposure in your intact skin is very, very low. And I always like to tell healthcare workers, okay, intact skin, very, very low. And then I ask them all to look at their hands and their cuticles in particular. And I don't know what yours look like, but mine are always trashed. So, you always have to be aware of what's going on with your hands, which is why you wear gloves. So this is all of the positive HIV people who picked this up from work starting in 1981. And you can see it is not zero, but it's not huge. So since 1981, I want you to imagine all of the healthcare workers in all of the United States since 1981 and how many positive HIV patients they took care of. And you can see just how very low that risk is. So the number one occupation, of course, is nurses, because they have the most risk. And then the laboratory people who work with a lot of blood. And physicians are next and on down the line. So it is very low, but it's not zero. And these are population studies, too, you need to be aware of. So if you get it, you get it 100%. You don't get it minuscule amount. You get it 100%. So you must be very careful while you work. Where does this happen? Body fluid exposures. High risk are obviously in blood, semen, and vaginal secretions, and then any fluid that has blood in it. So if you're new to healthcare, you must understand that patients sometimes will spit at you. And if there's blood in that and you get it in your face, that's an exposure, considered an exposure, so you need to report that. And then any other surgery, fluids, like especially if you work in surgery, synovial fluid, pleural fluid, all of that. Low risk fluid is saliva, tears, sputum, urine, stool, which is where you see most of the fluids. It's not usually the other ones except for blood. So if you have an exposure, don't panic. The high-risk exposures are a deep injury to a hollow bore blood-filled needle. So I want you to imagine somebody's drawn some blood. The needle is full of blood, and if you don't have the safety device engaged and you happen to poke yourself with that blood, that is a high-risk exposure, and they need to be reported. So this is direct contact with a concentrated direct contact with high-risk fluid. Another one, if you work in the lab, which I did for many years, direct contact with a concentrated virus. So if you work in a lab and you do testing for HIV, then obviously this would be a high-risk exposure. At risk, so it's a lower risk, is a needle stick or a laceration from an instrument visibly contaminated with blood. So a scalpel is a lower risk than a contaminated needle. And then exposure of a wound or mucous membrane is you are at risk. Low risk is a superficial injury, not causing bleeding. So let's say, for instance, a patient should scratch you. No bleeding, not a problem. Exposure of a closed wound or a mucous membrane. So part of what you'll do, some of you maybe, is do wound care. There is risk, but it's low risk, and you need to be you would be wearing gloves anyway. Prolonged blood contact over a large area of your skin. Just like I said, hands often have small cuts and scratches, and if you work in your garden and you have scratches from dealing with blackberries or roses, this is not contact skin, that's contact. So, and then a bite is low risk. Oh, go back. No documented risk of contamination of intact skin. So in a small area. So if you were to have just a little splash on your arm, for instance, I wouldn't be concerned. You just wash it off. It would not even be a reportable, although your specific employer might want to know about it, but they wouldn't fill out paperwork. So what if the bad thing happens and you have a needle stick? Infection after a needle stick, and you have a positive patient. So this